for sharing the Saturday morning with me. I hope everybody has a cup of coffee, or depending on which part of globe you are. So we're going to talk a little bit about how to diagnose acute kidney injury, pathophysiology of hepatorenal syndrome, management of hepatorenal syndrome, and implication of hepatorenal syndrome reversal on liver transplant candidacy. We all know that creatinine is a breakdown product of creatine phosphate, which is synthesized in muscle, and then it is methylated and then transported through blood to the other organs. Creatine is converted to creatine kinase, and then there is a spontaneous formation of creatinine that occurs during this reaction. Why do we use creatinine to assess the kidney function? Because it is produced at a constant rate based on muscle mass. So it has implications in patients with cirrhosis. Patients with cirrhosis have decreased synthetic function of the liver, so the serum creatinine is relatively lower than compared to those patients who don't have cirrhosis because of the decrease in muscle mass, poor nutritional status, and decrease synthetic function of the liver. There are various measures of renal function. We all know about serum creatinine, which is a time-tested biomarker. However, it is fraught by gender differences. It also underestimates creatinine clearance in patients with cirrhosis. It's also a poor indicator of severity and does not predict the reversibility of renal injury in patients with cirrhosis who are liver transplant candidates. Creatinine clearance in patients with cirrhosis. There are other biological markers such as statin C and NGAL, which can be used as an adjunct to serum creatinine for estimation of renal function. We all know about estimated eGFR, which we get with every creatinine that we order, and it's a calculated number. There are various equations over the last many years. So this was a meta-analysis of 25 studies of close to 4,500 patients with the median age of 52 years, and 37% were women. And what this meta-analysis found was that serum creatinine-based equations overestimate a measured GFR, and cystatin C-based equations underestimated GFR. However, all equations overestimated GFR when the measured GFR is less than 60 ml per minute. So if you use the CKD epi cystatin C, the overestimation is close to 10.3 ml per minute. Using GRAIL is 12.6, and MDRD6 is 15.7. So in the nutshell, none of these equations, they are helpful, but you have to also use other measures to assess the kidney functions. The spectrum of renal dysfunction in patients with cirrhosis varies widely from normal liver function for normal renal function to severe acute kidney injury. And severe acute kidney injury could be sustained acute kidney injury requiring liver transplant, and also there are patients with CKD who can develop acute on chronic kidney injury and end-stage renal disease patients. So this is a modified Dreifel criteria, which basically stage the acute kidney injury into risk, injury, and failure. Risk is stage 1, which is increase, and it has a serum creatinine criteria as well as urine output criteria. Most of the time in the clinical setting, we use serum creatinine criteria. So the serum creatinine criteria is increase in serum creatinine more than 0.3 milligram per DL, or 1.5 to 2 times increase in serum creatinine from the baseline within 48 hours. And this is further subdivided into stage 1A, where the serum creatinine peaks less than 1.5, or 1B if serum creatinine is greater than 1.5. The stage 2 is injury, where it is still reversible, but If stage 1 is most of the time reversible. So it is defined as 2 to 3-fold increase in serum creatinine from baseline, and stage 3 is greater than 3-fold from baseline or initiation of renal replacement therapy. So these are the various studies that had looked at the prevalence of acute kidney injury and the causes of acute kidney injury in patients with cirrhosis. The sample size varied anywhere from 100 patients to 2,000 patients. Two studies talked about the AKI prevalence, which was around 47 to 53%. Majority of the patients had hypovolemia and ATN, followed by ATN and HRS. The incidence of HRS in these studies varies anywhere from 12% to 32%. This is a prospective multi-center cohort study which enrolled adults greater than 18 years with decompensated cirrhosis across the world. This is hot off the press. And what they found was there is the geographical distribution of AKI stage 3 in patients with cirrhosis varies. So here, the light blue is less than 25%. Little darker blue is 25 to 39%, and greater than 40% is the dark blue. So the areas of Latin America, areas of Mexico and South America, as well as India and some part of Africa, had the AKI peak stage 3 in this study. And when they further subdivided the cohort, so these are mainly the hospitalized patients. So what they looked at, they found that 2/3 of the patient had AKI, and of these 2/3, 858 had hypovolemic acute kidney injury, 253 had HRS AKI, 216 had ATN, and 129 had other causes. Of those 1,456 patients, greater than 50% had stage 1 AKI, and followed by stage 2, and only 20% had stage 3 AKI. So this study looked at the survival of patients with AKI by stage of AKI, and what they found that they combined stage 2 and 3, and what they found was that if you have stage 2 or 3 AKI, the survival significantly drops down to 50% at 30 days and 36% at 90 days. However, and also if you have stage 1, but if your serum creatinine peaks at greater than 1.5, then also the survival is lower compared to stage 1A. This is another study of 2,063 patients with AKI and cirrhosis. And what they found was majority of the patients had pre-renal AKI, and then followed by HRS AKI was present in 12% of the patients, ATN was present in 30% of the patients, and 7.2% were unclassified, and 6% had other causes of AKI. And what they did, they looked at the 90-day mortality. And if you see, like, patients with HRS AKI and ATN had the highest mortality, 90-day mortality, compared to pre-renal as well as other causes of AKI. Next, this study also looked at the prevalence of RRT by AKI phenotype, and what they found was, so there were 2,063 patients with AKI, 374 were hospitalized with cirrhosis and AKI requiring renal replacement therapy. Of these, 17% were HRS AKI and 62% were ATN. So mainly hospitalized patients with AKI requiring RRT predominantly have ATN, and their 90-day mortality for the ATN patients was 66%, and HRS patients were around 50%. So the moral of the story is that RRT, or renal replacement therapy, should be a bridge to something. Otherwise, these patients carry very high mortality and poor prognosis. So this is a study by Dr. Allegretti and their group. What they looked at the outcomes of patients with AKI listed for transplant and not listed for transplant. So I'm showing the results. I'm showing the graph, which is mainly listed for transplant. So there were 131 patients who were listed for transplant. 62 had HRS, 69 had ATN. And if you see, around 50%, more than 50% of the patients in the HRS group were transplanted, and in this group, around 46% got transplanted. So if they did not get transplanted, they died. So mortality is pretty high, and very small number of patients were alive, and only 3% were alive without RRT. Again, in the ATN, again, 52% of the patient died, and only 1% were alive without RRT. So the take-home point from this slide is once they develop HRS or ATN, they should be listed for transplant. Otherwise, mortality is high, and they have at least listing for transplant, or transplant provides them survival benefit. Mm-hmm. So this is this is hot off the press. This study came last year. This is mainly the Acute Disease Quality Initiative and International Club of Ascites consensus, where they tweaked the AKI definition, and similar to what we have for the rifle criteria. Mainly increase in serum creatinine greater than 0.3 milligram per DL within 48 hours, or greater than 50% from baseline value known or presumed within the prior 7 days, and or urine output less than 0.5 ml per kg for greater than 6 hours. The lowest stable serum creatinine value obtained in previous 3 months may be used for the diagnosis and staging, and if there is no value available in the previous 3 months, the most recent value up to 12 months prior may be used. And this was the definition of baseline creatinine from Dr. Angeli and their group. They basically are similar to what our ADQI and ICA consensus recommended, mainly serum creatinine obtained in last 3 months. If there is greater than one value in the last 3 months, then use the value closest to the admission. If previous serum creatinine value is unknown, then use the serum creatinine on the day of admission. And this is the definition. This is mainly the criteria for HRS AKI, which is a functional form of acute kidney injury, and it's usually a diagnosis of exclusion. So mainly it is very important to have patients with cirrhosis and ascites. If patient does not have ascites, they don't have HRS AKI. And AKI diagnosis should be based on rifle criteria, no response to consecutive 2 days of diuretic withdrawal or plasma volume expansion with albumin 1 gram per kg body weight, absence of shock, no current or recent nephrotoxic drugs, no macroscopic sign of structural kidney injury such as no proteinuria, no microhematuria, and normal ultrasonography. However, the ADQI and ICA joint consensus says that if there is no value in past 3 months, we can go back up to 12 months to find the baseline creatinine. That's the difference. And here, mainly, they are recommending absence of improvement in serum creatinine or urine output within 24 hours following adequate volume resuscitation when clinically indicated. They also recommended that the HRS can occur in patients who have pre-existing kidney disease also. So that's the difference in the newer definition. So basically, absence of strong evidence for an alternative explanation as the primary cause of AKI should be considered as HRS AKI. So this was the criteria. We previously HRS1, which is a little bit more progressive and carries poor prognosis, was based on serum creatinine greater than 2.5 milligram per DL within 2 weeks. And most of the studies of Terlipressin were based on our old classification. So this is now called the HRS AKI, and this is the definition. Then HRS type 2, which was mainly gradual decline in serum creatinine with greater than 1.5 milligram per DL, usually seen in patients who have mainly refractory ascites. And this term is now called HRS non-AKI, and this is further divided on as HRS AKD, acute kidney disease, and HRS CKD, based upon the EGFR less than 60 ml per month duration. So if it is less than 3 months without any structural damage, then it is HRS AKD. If it is greater than 3 months, then it is called HRS CKD. The pathophysiology of hepatorenal syndrome is very fascinating, and it is not as simple as it looks in this diagram. There are many players. So there is extreme portal hypertension, patients with cirrhosis and ascites. Splanchnic vasodilation is the hallmark of portal hypertension, along with central hypovolemia. It stimulates the neurohormonal pathway, like sympathetic nervous system, renin-angiotensin system, and ADH axis. As a result of that, there is a balance between intrarenal vasodilators. The main players here are prostaglandins and nitric oxide and many others, and intrarenal vasoconstrictors, again, angiotensin 2, endothelin 1 and 2, and other factors that we probably don't know at this time. This balance causes limitation of decrease in the renal blood flow because there is pre-glomerular arterial vasoconstriction, and then which causes no or slight decrease in glomerular capillary pressure, which further causes no or slight decrease in glomerular filtration rate. Whenever there is a second hit, such as intravascular volume depletion, infection, anything else, that further tips the balance in the favor of intrarenal vasoconstrictors, which further reduces the renal blood flow, further reduces the glomerular capillary pressure, and decreases the EGFR. So basically, the kidneys are maximally squeezed, and they feel that it's a pre-renal physiology, and a functional HRS sets in. So how do we what should we do? So whenever any patient who meet the criteria of acute kidney injury, need to rule out the inciting factors and treat them, rule out any kind of nephritic or post-renal etiology of renal disease. And if all of these are met, then look at the urinary biomarkers, mainly urinary sodium, FeNA, FeUria, and urine sediments. So again, if FeNA is less than 0.5%, FeUria less than 21%, it's suggestive of pre-renal physiology. If there is no cast and non-response to the plasma expansion, then it favors HRS AKI. Again, if FeNA is greater than 1%, FeUria greater than 33%, and you see muddy brown cast or any evidence of tubular injury, then it favors ATN. But life is not that simple, right? It is complicated. Most of the patients fall in this middle category where FeNA is between 0.5 to 1%, FeUria is 22% to 33%, and that is the indeterminate AKI. In that scenario, you can use urinary NGAL, which is sometimes available in some institutions. An NGAL of less than 100 microgram per gram of creatinine favors HRS AKI, and NGAL greater than 110 on day 1 and greater than 220 on day 3 favors ATN. The NGAL at day 3 is more sensitive and specific. However, if you wait for day 3, you are already behind the 8 ball, and we have already damaged the nephrons. So NGAL is a 25 kilodalton glycoprotein. It appears as early as 1 hour after the injury, and accumulation is proportional to the severity. It is produced by neutrophils, epithelial cells, including tubular cells. It is filtered by glomerulus and reabsorbed by proximal tubule. it is released mainly in the setting of acute tubular injury, and that's why higher number favors ATN. But it can be elevated in the setting of infection and also especially urosepsis. So in patients with infection, I don't think we get the, we have to be very careful when we are using NCAL. So the fluid challenge, again, is a diagnostic as well as therapeutic option. So mainly, this is an older graph. Mainly, it was published in 2008, adapted from Dr. Garcia Sal's review. And so, in the hospitalized patient, the incidence of acute kidney injury was around 20%. 19% were AKI, and 1% were chronic renal failure. Of these, 2/3 had pre-renal etiology, 32% had intrarenal, and less than 1% had post-obstructive etiology of acute kidney injury. And what they found was that 2/3 of the patients were volume responsive, and those who were not volume responsive, they had either type 1 or type 2 HRS. But, when we give the fluid a blanket statement of saying like give albumin for 2 days, it's very difficult to assess the volume status in these patients because our patients are usually, they have ascites, they have lower extremity edema. So in this small study of 53 patients, Dr. Velez and their group basically looked at the inferior vena cava diameter, IVC collapsibility index, which is IVC diameter maximum minus IVC diameter minimum divided by IVC diameter maximum. So this is a formula that they used. And they defined volume depleted as IVC diameter less than 1.3 centimeter, IVC collapsibility of greater than 40%. The fluid expanded were if the IVC diameter was greater than 2 centimeter and IVC collapsibility was less than 40%. And intestinal abdominal hypertension was if IVC diameter was less than 1.3 and collapsibility was less than 40%. And what they found was, so they did this point of care echo before the patient received the fluid and after. And what they found was all these patients received 1 gram per kg body weight of albumin for 2 days. Only 19 patients were fluid depleted. 15 patients were still fluid depleted. 11 patients had fluid expanded, so they used furosemide, Lasix in those patients, and 8 patients had intra-abdominal hypertension. So basically, one size does not fit all, and I think we need to incorporate this point of care echocardiogram to determine the volume status. So of these 15 patients, they received more IV albumin, and their AKI improved in 40% of these patients. So, they were able to salvage AKI. They were able to reverse AKI in these 15 patients, whereas these 11 patients, they gave IV furosemide, and AKI improved in 30% of the patients. And these patients, when they had intra-abdominal hypertension, they received paracentesis, and AKI improved in 50% of the patients. So I think we need to include this in our practice of evaluating a patient for their volume status. So now come to like, what can we do? We know we have diagnosed a patient with AKI. We know that they have poor prognosis. What are the therapeutic options for these patients? So mainly, liver transplantation is the therapeutic option for patients with HRS AKI. If there are no major comorbidities and patient meets the criteria for listing, these patients should be listed. However, they don't get liver right away. So, we need to do something in the meantime. So other options is lowering the portal pressure. So how can we do that? We can use intravenous splanchnic vasoconstrictors as well as volume expansion with albumin that theoretically improve the effective arterial blood volume and improve HRS. And so these these could be used as a bridge to transplant. So terlipressin was used by the entire world except for United States for last 15, 20 years. However, we did a couple of studies in the past, and it did not meet the efficacy criteria. So this was the confirmed study in which was published in 2021, and Michigan was one of the highest enrollers with other centers, where they looked at the efficacy and safety of terlipressin and albumin in the treatment of type 1 hepatorenal syndrome. So these were the inclusion criteria. Here they used a stage 2 and 3 patients with AKI. So in the previous studies, serum creatinine greater than 2.5 was considered as the point of inclusion, whereas in this study, they reduced the serum creatinine to 2.25. And this has implication, mainly, if you want to start the patient, if you want to reverse the HRS, you have to start earlier than later. So this is the graph. Basically, 309 patients were eligible for the trial. 199. So it was 2-to-1 randomization. So 199 were assigned to receive terlipressin, and 101 were assigned to receive placebo. Finally, 43% completed 90% follow-up, and 51% completed the 90-day follow-up in the placebo arm. And what they found was patients who were treated with terlipressin and albumin had 32% response to HRS reversal compared to 17% in placebo group. And what they found was patients who have serum creatinine less than 3, the response rate was higher, around 50%. If their creatinine was greater than between 3 to 5, the response rate was 32%. And when the serum creatinine was greater than 5, the response rate was only 8.7%. And that's why they have put the upper bound of serum creatinine 5 or above, where it will be futile to use terlipressin. Terlipressin is also associated with high incidence of acute respiratory failure in these patients, so compared to placebo. So in order to tease out which patients were those who were at risk for respiratory failure, what they did, they reanalyzed their data using the ACLF Cliff SOFA classification to classify the patients as ACLF 1 and 2 versus ACLF 3. So ACLF 3 is those patients who have 3 or more organ failure, and ACLF 1 with 1 organ failure, and ACLF 2 is with 2 organ failure. So because these patients had incidence of renal failure, everybody had at least grade 1 ACLF. And what they found was the response was higher compared to placebo if they have ACLF grade 1 and 2. However, if they have ACLF 3, the response is similar to the placebo to terlipressin and albumin. And that's the reason there is a package insert which says do not use terlipressin in patients with ACLF 3. They were also looking at the respiratory failure. Here, the top graph basically shows the terlipressin group at baseline. There were 5 patients who had respiratory failure. At the end of the study, 16 patients in the terlipressin group had a respiratory failure. However, in the placebo group, the respiratory failure was similar before as well as after. The patients who have grade ACLF 3, they had higher incidence of respiratory failure compared to those with ACLF 1 and 2, and death from respiratory failure was also higher in patients with ACLF 3. So this is the package insert. Basically, start terlipressin at 0.85 milligrams IV push every 6 hours and assess the serum creatinine at day 4. If serum creatinine is decreased by 30% or more, then you continue it every 6 hours. And then continue until 24-hour patient achieve a second consecutive serum creatinine of less than 1.5. If the serum creatinine is decreased by less than 30%, they recommend to increase the dose. And if the serum creatinine is at or above the baseline, then discontinue. So these are the discontinuation of vasoconstrictor recommendation from ADQI and ICA Joint Consensus is when serum creatinine returns to within 0.3 milligram per DL as opposed to less than 1.5 in the package insert. If they have severe adverse events, which is a no-brainer, serum creatinine does not improve after 48 hours or maximum tolerated dose. If they progress to RRT or renal replacement therapy and a maximum of 14 days of therapy. So then, we were so used to midodrine and octreotide and knowing that my data for midodrine and octreotide is not great, but we were using it because something is better than nothing. So this was a study which compared Terlipressin and albumin versus midodrine and octreotide in patients with hepatorenal syndrome. So there were 49 patients who were randomized, 27 in the Terli group and 22 in the midodrine and octreotide group. And they analyzed 27 patients in this group, and they analyzed 21 patients because one patient was censored as they received liver transplant at day 2. The endpoint for this study was complete response, which was decrease in serum creatinine to less than 1.5 milligram per DL. Partial response was greater than 50% serum creatinine decrease from the baseline to greater than 1.5 milligram per DL, and no response was serum creatinine decrease less than 50% from baseline. And what they found was that Terlipressin arm is more efficacious compared to the midodrine and octreotide arm, whether it is a complete. So here the dark bar is complete or partial response, and a white bar is the complete response. And again, here in midodrine and octreotide, complete response and complete response and complete and partial response. So again, basically, Terlipressin and albumin is superior to midodrine and octreotide. And then they looked at survival stratified by response. In the Terlipressin arm, those patients survived had those patients who had response and survived, and they had better survival compared to those who did not have a response. And in octreotide and midodrine group, there was no difference in survival, whether they have a response or not. So now the question is, these patients with albumin, these patients with who received also albumin in the confirmed trial, would the respiratory failure related to the albumin? So they also looked at the predictors of respiratory failure, and what they found was those patients who have high systolic blood pressure as well as low oxygen at the beginning of the at baseline, they were more likely to develop. They were the independent predictors of respiratory failure, and they also used albumin, total dose of albumin, as a continuous variable, and it was not significant. The question is now, albumin infusion alone, can that reduce the mortality? And it's basically, there was a answer study of 431 patients, which it was an RCT or randomized controlled trial, which compared the standard medical therapy to standard medical therapy and albumin twice a week for 18 months. In this study, they found that there was a mortality reduction by 38% in the albumin arm. However, it was not replicated by the two other studies. The MCAT study of 172 patients did not find any difference in death or infection. And then a TIRE trial of 777 patients, where albumin infusion for serum albumin less than 3 until discharge or 14 days, found no difference in mortality, and there was a high respiratory failure in non-LVP or non-SBP related indication for albumin. So what does how does response to terlipressin and albumin affect the transplant outcomes? So this was a study of 113 patients. Of these, 86 with HRS AKI were on the waiting list. They included 82 patients, 43 were responders to terlipressin and albumin, and 39 were non-responders. Of these 43, 30 got transplanted. Of these 39, 30 got transplanted. And what they found was that those patients who responded to terlipressin and albumin had a lower rate of chronic kidney disease at 1 year. So that's important, right? Because you transplant somebody, and if they develop post-transplant end-stage renal disease, then they will require a kidney transplant after liver. So now, liver allocation and renal insufficiency. We know that serum creatinine is one of the components of MELD score, and it is one of the overweighted component of MELD score. So we showed that if we have two patients with same MELD score, and if you change their creatinine, so every unit increase in creatinine, keeping the serum bilirubin and INR same, had 11% lower risk of waitlist mortality. However, if every unit increase in bilirubin for the two patients with same MELD score is associated with 10% increase in waitlist mortality, and INR has no difference. So although serum creatinine is associated with waitlist mortality and post-transplant mortality, but if they are on the list with two patients with same MELD score, the person with high serum creatinine probably has better synthetic function of the liver. And then survival benefit of liver transplant, we based on that, we wanted to look at what is the survival benefit of liver transplant and how the serum creatinine affects it. So survival benefit was defined as post-transplant mortality divided by waitlist mortality with 5 years of follow-up. If the hazard ratio is greater than 1, then these patients are waitlist advantage. And if it is hazard ratio is less than 1, then they had advantage from transplant or survival benefit. Sorry. And what we found was for MELD score between 24 to 40, no matter how high is their creatinine, they will get survival benefit from liver transplant. So these patients should be listed and transplanted. So the question comes that when you treat their HRS, their MELD score will go down, and that will probably reduce their priority for transplant. But if you don't do anything, then they have higher waitlist mortality because transplant doesn't happen right away. It takes a little while. The question is, and also terlipressin, if you use terlipressin and albumin to get a response for HRS reversal, these patients also have better outcomes. So this is a conundrum. And then in order to address that, there are three countries which have MEL lock policy: Spain, Italy, and Switzerland. So basically what they do is if a patient is treated with terlipressin and albumin, and if they have reversal and their MELD score goes down, they usually lock their MELD at that point so that they can get priority for transplant. Most important thing is not to have acute kidney injury. And what can we do to do that? So mainly prophylactic antibiotics for GI bleed, use of albumin and antibiotics for spontaneous bacterial peritonitis, albumin replacement for large volume paracentesis greater than 5 liters. And this is something which we have seen like happens in the community, that patient get their paracentesis and they do not get their albumin, and they come to they would get admitted with AKI, and then avoidance of nephrotoxic agents. This is something that I wanted to just present and open the discussion, mainly what can we do to prevent perioperative AKI, because patients will have acute kidney injury after transplant, during the early post-transplant period. And there are a couple of things here. So the first study basically compared the normothermic liver graft perfusion to standard cold storage, and that reduced the post-perfusion syndrome. There is no data on AKI. And then there are a couple of trials with intra and post-operative Terlipressin. In one study, the post-transplant AKI was not prevented by Terlipressin use. There was another study which basically of 41 living donors, which showed there was a lower post-LT AKI with Terlipressin use. And then these are two older studies where they looked at phenaldopam that may preserve kidney function. But these studies were from 2004, and I haven't seen any further studies with phenaldopam in the recent days. So coming back, patients with decompensated cirrhosis and ascites, they are at a higher risk of AKI. Once they have AKI, the most important thing is to characterize or phenotype the patient. What kind of AKI do they have, and what is the severity of it? Based on that, you can divide them into pre-renal, renal, and post-renal. Post-renal is very rare, but if it is present, then get a urology consultation for obstructive uropathy. If they are pre-renal, and if they are volume non-responsive, could be HRS AKI or HRS and AKI. Early initiation of vasoconstrictor therapy is recommended. ATN, progression to stage 3 AKI despite treatment. These patients, if they have a pathway to liver transplant or they are liver transplant candidate, then they should get RRT or renal replacement therapy regardless of etiology of AKI. But if they are not liver transplant candidate or do not have a pathway to early transplant, then at least a trial of renal replacement therapy be considered in patients with ATN, and there should be a palliative care consultation with goals of care discussion. So in conclusion, AKI is quite common among hospitalized patients with cirrhosis. It's one of the most ominous complications and carries very poor prognosis. Recognition of phenotype and early management is the key to improved outcomes. Terlipressin and albumin may reverse HRS AKI and serves as a bridge to transplant, which is the only curative option. And MELD exception for HRS AKI treated patients should be considered globally as a part of the allocation in the form of a non-standard exception. Thank you so much, and I really appreciate the opportunity to present.
Dr. Sharma, thank you. Thank you so much. That was a wonderful talk. I'm sure our audience will agree with that. Right now, I think AKI, as you mentioned, it's such a significant problem right before the transplantation. My question is, many of these patients, if you treat with the Terlipressin and improve, potentially, partially, maybe, what is their implications after the liver transplantation? Does improvement benefits after transplantation? That means that does it reduce the risk of having CKD or reduce the requirement of RRT after their transplantation? If there are partial response or a full response, how does that impact their outcomes?
So if I'm understanding your question correctly, there are two parts to the question. Number one is like if they have reversal of HRS post-transplant, what are the implications? Whether they have lower acute kidney injury, whether they require less renal replacement therapy, and long-term, what is their whether they have what is the progression of CKD in these patients. So the patients who respond to Terlipressin and albumin and get transplanted, it has been shown that they require less renal replacement therapy in the early post-transplant period, and also have less incidence of acute kidney injury in the early post-transplant period. There was one study that I showed, basically that was the only independent predictor. If the non-responders to the Terlipressin and albumin increases the incidence of, increase the risk of chronic kidney disease at 1 year. So any kind of AKI is a risk factor for post-transplant ESRD or CKD progression. And then the other question, before the transplant, again, if the patients are listed, I think the fear is that once their creatinine goes down, once they respond, their MEL score drops. So would they lose their priority, or would they lose their time on the wait list? And that's what it is. The MEL score, when we update the MEL score, it is valid for 1 week. And most of the time, the patients who have HRS, they have really high MEL scores in like high 30s and close to 40s. So those are the patients, if within 7 days, if they don't receive transplant, then probably yes, their MEL score will go down and will affect their priority. But at the same time, I think the debate is ongoing about MEL lock or non-standard exception for these patients.
Thank you. Can you unshare your screen? Yes, so we can see you. Beautiful, thank you. And we have a very robust audience group here today. A very prominent hepatologists are from around the world, and I see Dr. Javis Chawla, Dr. Dharmesh Kapoor, Rishi Samant, many more. I just can tell you that each and every individual in our audience is pretty well known on their own. So let me ask Dr. Dharmesh Kapoor to chime in first. Dr. Kapoor, please. It's your favorite topic, I know.
Hi, Sanjay. That was a great talk, Dr. Pratima. But I think maybe in the conclusion slide, you could have added that our understanding of acute kidney injury in patients with decompensated chronic liver disease is still a work in progress.
Absolutely.
So I think nothing sums up this particular topic better than this statement. So there are so many problems with the International Club Ascites definition, the time period that you need to wait, the fluid boluses. In the passing, you've made a reference to all of that. And one thing which probably also needs mentioning is the mean arterial pressure when you're talking of patients who've got acute kidney injury. So is it that all pre-renals who are volume responsive also are the same? The probable answer is no. Is creatinine the only determinant of kidney dysfunction in patients with liver disease? The absolute answer is no. More and more we are seeing patients with metabolic syndrome and the proteinuria definition of kidney dysfunction coming in, and which has got implications both in establishing the diagnosis pre-transplant and how we manage these patients post-transplant. So I think this is a huge topic, and probably every slide is worth a talk on its own. But at the end of the day, the important thing is in certain situations, no matter what you do, you have to take your patient to transplant. If you can take your patient to transplant without using organ support, that is the best case scenario. If you can't, then try to get transplant on board when the patient has been on organ support for the shortest period of time. So I think these are the 2 points I would wish to make. Thank you.
I completely agree with you. And I think, these 48 slides, I think you're absolutely right. Every topic, you can have a debate and you can have oodles and oodles of literature to cite. So I apologize, if I haven't included most of the work that has been done across the globe. But yes, there is the mean arterial pressure is the most important thing, to increase the mean arterial pressure by 10 to 15 millimeter of mercury when these medications have been used. And also, I think I haven't talked about norepinephrine, which is mostly used in India. And there was, I think, I want to mention this study. This was, I think, probably in 2007 in Red Journal, where they compared the Terlipressin and norepinephrine head-to-head comparison, and they found there was similar efficacy, but the cost of norepinephrine was low. So absolutely, this is work in progress, and I hope we find answers. And currently, we do not have enough understanding of volume status and all these kind of things. So thank you for your comments.
Thank you. Dr. Mubin Khan has a question. Dr. Mubin Khan, for the audience, please introduce yourself and then ask the question, please.
Good morning, everyone. Great talk, Dr. Sharma. This is Mubin Khan from Chicago. I'm a hepatologist and currently in gastroenterology training. In fact, I was in service till yesterday. As you said, there are many answers. Many questions for more than the answers we have, and there's a lot of debate, especially among the different specialists, nephrologists, and us, and as you rightfully mentioned, there are many of these patients come into this middle category where they're not in this indeterminate AKI category, where there's a lot of tussle between nephrologists and GI or hepatology, where we don't have urinary NGAL. So how do we make out a differentiate between ATN and AKI HRS, and is there any harm in continuing octreotide? Let's say even if it's an ATN picture, if it's not a clear picture, what's the harm in continuing octreotide in that scenario since it's not clear on the either side? Thank you.
That's a great question. So again, I think if I'm understanding your question correctly, is that in patients who we don't know clear cut whether it is ATN or renal cause of AKI versus pre-renal cause of AKI, what is the role of octreotide in those patients? So first of all, I want to say that octreotide and midodrine can be used in patients who have maybe the risk, their creatinine is tad bit up. You don't want to use Terlipressin. The Terlipressin is usually recommended if they have stage 2 AKI. Theoretically, octreotide will cause the splanchnic vasoconstriction, and it should improve the renal blood flow. So if there is any pre-renal component, and midodrine will increase the blood pressure. So if there is any pre-renal component, and the kidneys will start to feel like they're alive again, or they have there's increased blood flow. So it should help, but I don't know the answer. What is the downside of it? The downside of it could be these patients can have some abdominal discomfort or gallstone formation and other kind of things, but there is no systematic research or data to suggest that there is a utility of that. So.
Thank you. Dr. Gudella, Mohan Sai Gudella. Dr. Gudella, please introduce and also before I ask a question.
Thank you so much for the opportunity. I am Dr. Mohan. I'm a final year intensive care medicine resident from India. And I would like to know your thoughts on, the vasopresses, if at all, such patients, like say, patient with cirrhosis in ACLF, presents with shock and is in ICU. And can we use, what is the impact of the combination of norepinephrine and vasopressin versus terlipressin alone in such kind of patients? So traditionally we give terlipressin, and if there is a shock, we shift to noradrenaline. So, but is there any benefit of using a combination of norepinephrine, vasopressin in resolution of HRS in such kind of patients? Thank you.
So these are very, very sick patients, and it has, the confirmed trial clearly showed that these patients with ACLF3, if you use Terlipressin in them, there is no no benefit, or that the reversal, HRS reversal is similar to placebo, or there was like no significant difference between placebo and terlipressin arm in ACLF3 patients. And also, once the kidney function has gotten so bad, it's unlikely that these patients will respond to the vasoconstrictors. In fact, these are the patients that a CRRT would be a better way of supporting them if they have a pathway to transplant.
Thank you. Dr.
Thank
Abbas
you.
from Pakistan. Jagam Abbas.
Yeah. Hi, Sanjay. Excellent presentation, Dr. Sharma. Do you have any experience of using Terlipressin infusion? Because in Terlipressin infusion, we give the lower dose of Terlipressin, and I have seen some of my patients, if we give them 1 milligram of Terlipressin acetate every 6 hours, they develop some ischemic changes. They may have some chest pain, and then I have noticed bluish discoloration of toes in some of these patients that these patients develop due to vasoconstriction that these patients may be having. So, as far as the side effects are concerned, what's your take about infusion versus intermittent higher doses of terlipressin?
This is an excellent question. Actually, when they designed the confirmed study, they should have used it as a continuous infusion because the levels are steady. There was I think most of the world, they use continuous infusion. The side effects are low. There was a study from Dr. Reddy and their colleague where they, I think it was published a couple of years ago, where they looked at IV push versus continuous infusion. The efficacy was similar, but the side effects were lower. So, because the package insert says IV push, doesn't mean that you cannot use continuous infusion. And I feel that continuous infusion is much better than giving them every 6 hours of IV push because of the reasons of like sudden increase and, the level goes down very quick at the end of the 6 hours.
Hi, that was a comprehensive talk, but I was wondering about the role of the heart in this whole situation. I mean, there is portal hypertension and renal, but I think the heart has to pump well, and that might be the reason why in ACLF there might be cardiac dysfunction on top of all these things. And so if the heart doesn't pump, I think there's a problem. And that's one comment that I have. The other thing in terms of HRS, sometimes patients, I don't know if there is HRS can develop in a patient who has a fully functioning TIPS because nephrologists, tend to make this diagnosis of HRS in anybody with cirrhosis. Sometimes they have TIPS and they don't have ascites and they come with AKI and they say it's HRS. And I can't figure out how they decide that a patient without ascites who has got a functioning TIPS can get HRS. That's one question. What your opinion on that? And the third thing is the difference between in post-transplant AKI, whether the piggyback versus IVC anastomosis influences, the AKI development in immediate post-transplant period.
So I think there are 3 questions. The first question is role of heart in patients who have ACLF3, right? And the second question is, the third question was role of IVC anastomosis in acute kidney injury. And what was your second question?
Whether you can develop HRS in a patient with functioning TIPS.
Yes. So the first question first, definitely the patient is super sick. There is cirrhotic cardiomyopathy and all those kind of things. So I think it's not 1 or 2 organs. I think it's just the entire patient globally. So I think when they are so sick, the most important thing is to make sure that we are doing everything and they have a path to something, not do something if they don't have a path to anything. So I would, if somebody is that sick and we know that they have severe HRS, they are intubated, their blood pressures are low, and heart is not working, and if transplant is, even in those patients, we need to have a palliative care or goals of care discussion in those patients, because they are very unlikely to survive because of all these organ failure. Number two, if somebody has a functioning TIPS, which means that they don't have any portal hypertension, acute kidney injury needs to be worked up thoroughly. I don't think it could be HRS unless and until patients suddenly develop like TIPS occlusion and they haven't, to a point that they have able to develop ascites. So I think that they need to work it up more thoroughly, the cause of that AKI. And last but not least, so post-transplant acute kidney injury has multiple factors. The anastomosis definitely plays a role, but in addition to this, it also depends on like how much blood did they require, how much products did they require, what is the organ type, like whether they got a DBD or DCD donor, and again, if their creatinine is higher going into transplant. So there are so many other factors into play. So I think it is very difficult to tease out the IV piggyback technique versus cavocestomy in development of acute kidney injury. Historically, I think when they used to have a different, like when they used to put a patient on bypass for the IVC anastomosis, that was associated with high incidence of acute kidney injury. But I'm not aware of any study which has compared head-to-head piggyback versus cavocestomy in development of acute kidney injury. So again, it is a multifactorial process of of factors which causes acute kidney injury in the immediate post-transplant period. I hope I answered your questions.
Thank you.
Thank you. And I think Dr. Raj Verma has a question here. Dr. Verma, please.
Hi, my name is Raj Verma. I'm with Minnesota GI, MNG. Thank you for the talk. I have a question on your penultimate slide and what you just very briefly mentioned, that if there is a path to transplant, unfortunately, that sums up everything. I mean, it's not that easy. Trying to get guidance, if someone is in a community hospital, if we do not have a transplant center of our own, and I'm just taking care of a patient who is super sick. Maybe he came in with ACLF, or it was the initial presentation and we do not know. And everything is up in air, whether transplant eligibility, sobriety, insurance issues, and complete transplant evaluation has not occurred yet. But the patient is super sick. We have tried midodrine octreotide albumin, failed. We have tried terlipressin albumin, failed. And in these patients, would you kind of give them benefit of doubt and kind of try to strong arm your nephrologist to give them RRT till the patient gets discharged and then goes to a transplant center and gets evaluated? In other words, what I'm trying to ask is, should I be more proactive in asking our nephrologist to offer RRT to these patients where all these balls are still up in air and we do not know yet if there's a clear path to a transplant for them yet? Because if they do not get RRT, as you know, these people are going to die.
Yes, that's an excellent question. And that's what I think is, in a community setting, unless and until, so transplant evaluation and listing is a long, arduous process. So if you think that octreotide and midodrine is not working, you don't have terlipressin, transfer those patients to the tertiary care center. Because I don't think that, the community hospital, even though everybody has the expertise, will be able to manage without the presence of that evaluation and other kind of things. Most of the time, these patients, once they come to once you are starting them on renal replacement therapy, they are so sick, they're unlikely to get discharged. They need to be transferred. So the take-home point that I'm trying to make is that these patients should be transferred to a tertiary care center or a liver transplant where they have a liver transplant availability sooner than later. So, and this is what we are doing statewide. Education is very important. There is no 6 months rule for alcohol. Well, most of these patients have alcohol-associated hepatitis. And the number of these patients have increased significantly, and these are young patients who are with the acute kidney injury or HRS AKI, who are not going to get better. So if they have a pathway to transplant, it is not going to happen right away. You cannot send them I think the transfer is the way to go. And I am sure, your tertiary care centers would love to have those patients, because most of the tertiary care centers have this multidisciplinary alcohol, liver disease clinics, and also they work with the transplant center to ensure that these patients, even though they did not have any sobriety or sober time, and they are high risk, and if they get survival benefit from transplant, and in a right patient, we can get them through transplant, and we can do all the AUD therapy afterwards. So that would be my suggestion. Don't try to, you have all the knowledge and everything, but you do not have the system level expertise. So send it to a system where they have that expertise.
Thank you so much.
Thank you. So
the problem is many times the transplant centers don't accept these patients, and that is what the community hospitals face. But we have seen so many people with alcoholic hepatitis who survive. I've had patients who have been sent to hospice because they have renal failure and AKI, renal failure and alcoholic hepatitis, and they have survived. So I think when it comes to a young alcoholic hepatitis patient who has renal failure as a predominant problem, but the synthetic function, etc., is okay, they have a chance of reversibility. And nephrologists will say, "Oh, if he's not a transplant candidate, no RRT." And that rule should be changed. I mean, we need to push nephrologists to individualized care. Now, if it's a 70-year-old person or 65-year-old person with hepatitis C or other liver disease is one thing, or NASH, or MASLD. But when it comes to young alcoholic hepatitis patients, I have seen numerous patients survive and get back to normal. And so I think we should push the nephrologists in that direction.
So I think, Dr. Ben, the point that you make probably also is a very important one, because all acute kidney injuries are not the same. So the typical patient that you're describing who goes to the hospice and gets better, where the level of care would be primarily what you've written as your prescription, are probably patients who might not have a physiology of HRS. So we forget oftentimes that they can have a primary glomerulonephritis. So these are the patients who have a completely different physiology, and these are probably the patients who are likely to survive in spite of us.
That's true, but they were sent from transplant center to hospice, and they came to me and they.
You got
So
muted.
the larger point I'm trying to make is that there is a huge gap in knowledge, because we treat all these patients alike, and there is a paucity of tissue diagnosis in the kidney injury / dysfunction in the backdrop of chronic liver disease. So that's a major problem we face in these patients.
Thank you. Dr. Sharma, you have any comment?
No, absolutely. And one size doesn't fit all. We all can give anecdotal examples of people that we have sent to hospice, or they are not a transplant candidate, and then with aggressive care, their kidney function gets better. Having said that, again, I agree with Dr. Kapoor that we don't have enough knowledge. There are gaps in knowledge. The reason I'm saying is to send them to a tertiary care center is that not everybody will get transplanted, right? The main thing is that they have more support system. The small hospital and community with a GI group may not have enough, nursing support to take care of their labs like every week. Like when we have a patient like this, we might be doing their labs every week, and we will be doing everything in our power to make sure that they get good aggressive care. Whereas, if you are in a community hospital, in a community setting, it becomes very difficult to take care of these patients. These are very resource intense as well as very sick patients, which require multidisciplinary care. So that was my point. But we all have anecdotal patients that we have sent to hospice and they got better. So again, we don't know everything.
I have one question. Like one slide that you presented where you compared Terlipressin plus albumin and compared with midodrine plus albumin, and there was a much better response with the Terlipressin per albumin, but there is a partial response in midodrine and octreotide as well. Now, do you have any experience or do you have any study to support that we start with midodrine and octreotide, and those who do not respond, they go to Terlipressin albumin and may potentially respond in that pathway rather than using Terlipressin albumin in all these patients from the beginning, because this is quite a costly drug in United States, at least. Of course, when you go to India, it is so cheap there, but here it just eats out all the money.
So again, I'm not prescribing Terlipressin and albumin to all comers of AKI, which is volume non-responsive. So there are guidelines which basically suggest that if they have stage 2 AKI, which means that they are more than 50% of they meet the criteria for injury. So in those patients who don't have that high stage 2 AKI, stage 2 or above, higher AKI, in those patients we can use octreotide and midodrine. But I'm not aware of any study which has looked at the failure of octreotide and midodrine and then using Terlipressin and albumin. However, there was a study by Dr. Wong and colleagues, which was published. It was looking at the role of TIPS in these patients. And what they did, they basically treated the patients with octreotide and midodrine, and those patients who had a response to the patients who had Terlipressin and albumin, those who have response to octreotide and midodrine, they basically injected those patients.
Can you unmute Dr. Sharma?
I am so sorry.
Yeah, got muted.
Yeah. So I don't. So basically, the patients who. So there was a study. When did I got muted?
Yeah, you just got a couple of seconds on.
Okay. So I said there was one study by Dr. Wong where they looked at the role of TIPS in the patients with HRS AKI, and what they found, they basically treated these patients with octreotide and midodrine, and those patients who responded to octreotide and midodrine, they put TIPS in those patients, and there was like they did well, but I'm not aware of any study which has looked at the graded response of like failed octreotide and midodrine and then using Terlipressin.
Thank you. And may I invite Dr. Jalal, Prasoon Jalal, if he is still available. Dr. Jalal?
Yeah, thank you. It's a great talk. One question, maybe I have missed it because I was in and out. In terms of albumin, in your practice, how much do you give? Because the main problem with the Terlipressin study was the over-infusion of albumin. Do you use a point-of-care ultrasound before you decide you have enough, or you have a set dose?
So in my practice, we still are using the 1 gram per kg body weight day one and over 48 hours. and then if they don't respond, then subject them to Terlipressin and albumin. And then albumin that we use during the study is anywhere between 25 to 50 grams. But if their albumin is already greater than 3, then we don't use albumin. Unfortunately, we do not have a point of care ultrasound, but I feel like that is the way to go.
Thank you. I think Dr. Ugonabo has a question. Dr. Ugonabo, you want to ask that question, Oni?
Yes. Hi, I'm Oni Ugonabo, PGY4 at Northwell. I have a question. Thank you so much for your presentation. I must say it's a very wonderful one. But my question is, when we're giving Terlipressin, do we put into consideration the map? Like, what is actually the goal map for this patient? Because some of them are like not hypertensive, and then they have like this HRS. So, like, what goal map do we use when we're using the Terlipressin?
So usually we use the map of greater than 65 or 10 to 15 millimeter greater than the baseline.
Thank you. I think we've pretty much come to the end of the meeting. If there's any other questions from the audience, from the last, I can give you 10 seconds here. Is there any other questions from anyone else? If not, Dr. Sharma, thank you for a wonderful talk. It's an honor to have you on our platform. The talk, there's a lot of requests already to me that is the talk's going to be available on the online. Yes, this talk's going to be available. We've taken the permission in the website, so please visit. If you have missed the lecture or if you want to revise the whole talk, please listen again. And really thank you everyone for joining us today, and we look forward to see you again in 2 weeks for another wonderful talk. Dr. Sharma, thank you so much.
Thank you for the invitation, and I really enjoyed the discussion. I think it was much more rewarding than the talk itself. So.
Thank you.